Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Welcome to this segment on HPV positive, recurrent/metastatic, otherwise known as incurable head and neck cancer. We know that we cure northwards of 90% of locally advanced HPV positive head and neck cancer. And while there is a human tendency to round high numbers like this to 100%, those of us who treat a high volume of disease know that unfortunately, those 5 or 10% of patients are very, very real. And therefore, we want to treat them with the goal of helping them live as long as possible. And I would argue even more importantly, with preserving their quality of life. Now, of course, the best way to do this would be to never meet them in the clinic in the first place. Dr. Sheth, I know you had some thoughts on that.
Yeah, I think it would be a missed opportunity not to talk about primary prevention. And I think we have a really great vaccine out there that is still being underutilized. And so some of the more recent data showed that in teens, only about 60% have been vaccinated, where the goal is 80%. And I think the other important data that's changed is now the CDC recommends that any individual up to age 45 can get vaccinated. And so it's just a PSA that I think if you're within this age group and it makes sense to you, it's a vaccination that you should consider getting. I think the last piece, though, is that due to the low uptake in vaccination rates and just the long latency period of the HPV virus, we're continuing to see HPV-associated head and neck cancer curves increase, and we may not see that really starting to plateau and come down till 2060. And so this is just an important reason that we should get out there and get vaccinated if possible.
Yeah, this is not STD prevention. This is cancer prevention. I'm a father of 3 daughters. I am not willing to ever acknowledge out loud that they're going to date, but to not vaccinate them, in my opinion, would be irresponsible. This can prevent cancer. So prevention, obviously, the best treatment. We know that is not happening at the rates we would like it to happen. And we know that cure rates, while higher than HPV negative, are far from perfect. And so with that demographic upswing that you've described, that is unfortunately very true, we know we're going to see more of these cases as the years go forward, and therefore the care is extremely critical. Dr. Patel, in standard of care clinic, before we get into trials, when you see a patient with HPV positive recurrent metastatic head and neck cancer in your clinic, what are you thinking about to talk to that patient about options?
Yeah, and so as we've talked about with HPV negative disease as well, one of the really critical studies in patients with recurrent or metastatic head and neck cancers was the KEYNOTE-48 study, which compared standard of care chemotherapy, which at that time was something called the extreme regimen, chemotherapy with platinum agents and an antibody called cetuximab, to an immunotherapy drug called pembrolizumab or Keytruda alone, or that immunotherapy combined with chemotherapy. And so in patients currently with recurrent metastatic HPV-driven cancers, that study has really informed our practice, and we use something called a PD-L1 score to help us stratify whether to treat patients with immune therapy alone or a combination of chemotherapy and immune therapy. But importantly, big picture for what we learned from that study was that both of those combinations with immune therapy alone or chemo and immune therapy are better options for patients than chemotherapy and cetuximab, which was the previous standard of care. So that's really the important distinction there. And then using that PD-L1 score to decide on immune therapy alone or chemo and immune therapy.
Dr. Sheth, I think we're all 3 of us clinical trialists. We're always looking for what's better. What are you most excited about for HPV?
Yeah, I mean, I think that we're still quite early into understanding some of these novel therapeutics, but there are now therapies that are really targeting the HPV virus. And without getting too much into mechanism, is can we directly target the HPV virus, shut down its machinery, and to help decrease viral replication and there make the disease less active. And so some of these new agents are being combined with immune checkpoint inhibitors like pembrolizumab, and there are ongoing phase 2 studies that have been, pretty promising. We've participated in them, and some of the early data that's coming out is that these combination strategies may be better than pembrolizumab on its own. And so I think this is just another one of those areas where we're going to need a confirmation phase 3 trial to show that it truly is better. But I am excited about the possibility of some of these HPV-directed therapies.
Yeah, I'm very much with you, right? In HPV-driven disease, we know it's a virally driven process. We know viral proteins that are pretty much always there, that are always foreign on the surface of the cancer cell, and that the immune system does know how to recognize, but needs a little bit of help with. And so there are a variety of approaches oriented towards these T cells, the immune cells that are best at killing cancer, therapeutic vaccination to help existing T cells, or technology called TCR to introduce T cells that can attack HPV-driven cancer. And there's even a therapy called CAR, which is, I'm not going to dive into the weeds of what CAR is, but another cell-based therapy that might be good for both HPV positive and HPV negative cancer cells. And so I think this idea of using the immune system to attack HPV-driven cancer, I think we're only in chapter 1 of a much longer story. We're at the beginning of the beginning. And with these preserved elements that come from the virus that look like nothing that belongs there in the human, I'm a really passionate believer that we can provide dramatic benefit to these patients if we get that right. Well, thank you for joining this segment on recurrent metastatic HPV-driven cancer.
Thank you again for joining us. This podcast was made possible by the generosity of our sponsors and you, our community. Please like and follow us on YouTube, Facebook, Twitter, LinkedIn, and Instagram. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.